few years, wow, a few years ago, my wife and I were talking about death and dying, and she said, you need to write your obituary, and you need to write all those things that you did. And I said, most of those things really don't matter very much. But so I wrote down, Bob Cranston used to be a doctor, and he has 13 grandkids. And I, named all the grandkids, and I made up Southern names, Billy Bob, and Sally Joe, and she liked that. But anyway, introductions are okay. Any CME thing you're supposed to declare if you have any conflicts of interest. I have none. But I do have a few things I did want to say just before I even get started. One is I've been a member of the CMDA for 25 or 30 years. Yeah, probably 30 years. And I'm a firm believer, if you're a physician assistant, a nurse practitioner, and you have interest in serving the Lord in different ways, not just overseas, but here in the US, I would strongly encourage you to look at some of the information of the CMDA over there. I'm a lifetime member, and I'm on the ethics committee. I firmly think it's a wonderful thing. I also wanted to say, Dr. Mitchell is one of my mentors, and that's an important thing to say, because he taught me a lot about medical ethics, and he still does. I just finished reading his newest book, which has been highlighted a couple of times, and I'd highly recommend that. The Hippocratic Oath is interesting, and we're not going to talk a lot about it tonight. It says a number of things, but one of the things it says is you need to honor those who have been important in your training. And I immediately thought not of the gastroenterologist who taught me something or the neurologist that taught me something. I thought about Ben Mitchell. So just wanted to say that, Ben. Okay, we can move on to the next slide if you want, and we'll talk about it. We all lose ground. We all fall down. And every day, in every way, you'll notice things, and some of them are completely normal. And in fact, one of the highlights of dementia is you don't recognize that you're losing ground. So if you're saying, I misplaced my keys again, man, maybe I'm losing it, you're probably wrong, But the point is, a lot of times, in fact, I read something this past week that says, as we age, we have a harder time accumulating new information, but some of our skills are just as good or better than they ever were. And so this isn't about that. This is about dementia. One of the slides today, I think it was Dr. Mitchell's early, talked about 100 kinds of dementia, and there really are a whole bunch. We do not use the word senile or senility anymore. It really just means getting old, and it's not a good term, and it's one of those politically incorrect terms. So if you hear somebody talk about she's getting senile, I was surprised with President Biden. People actually in the press who should have known better were talking about he's getting senile, and I'm like, yeah, well, he's 84, so he's old. Yeah, I mean, but what they should have been saying is he clearly has some cognitive loss. And nobody was saying that. We'll move on to the next slide. One of the things on the dementia definition that's important is it's an acquired deficit. So if somebody is born with significant cognitive loss from birth, that's not dementia. That's something else. It's a decline in one or more area. For many years, they used to say it had to be a decline in at least two areas. And for most people, they seem to equate memory loss with dementia, which is true. But language, executive function, complex attention, perceptual motor, and then social cognition. Now you might say, well, I already am weak in some of these areas, right? And we all are. If you look at the whole list, you say, well, I'm weak in a couple of those areas already. Social cognition, for instance, sometimes women think all men are weak in social cognition. Um, Complex attention. Um, I worked on the ethics committee, and there's some really brilliant people, and they're talking all around me. And after a while, I just feel like that Far Side commercial where the boy raises his hand. He says, "My brain is full. I need out of here." Anyway, complex attention, but it's a decline in one of those areas. So if you were always bad at remembering the word you wanted and you're still bad, that's not a decline. Okay, we'll move on. Bunch of risk factors. Let's see. Oh, epidemiology. I'm sorry. Yeah, let's go back there. 3% to 22%. Here's some statistics. You can read them. I don't have to read them to you. But the point is, it's growing. And as the world ages, as we have more and more older people, it's expected to double within the next 35 years. 6 million Americans already have it. It's the fifth leading cause of death, according to some studies, the sixth leading cause of death. And we'll talk a little later about how does dementia actually kill you? Because you might say, well, if somebody forgets stuff, why does that make them die? So we'll talk about that. There's a slight female to male predominance. There are some geographical predominances. We don't understand all of them. There's a lot about dementia we don't understand. But again, dementia is a category, like it's an umbrella, right? And then we have to, if you really want to solve the problem, you have to break it down and say, which kind of dementia are you talking about? Frontal temporal dementia, Parkinsonian dementia, and on and on. Risk factors. Some of these are so obvious, and some are very preventable, and some you can't do anything about at all. The incidence of type 2 diabetes has gone up dramatically in the United States, along with the incidence of obesity and hypertension, but they're kind of additive as being risk factors for dementia as well. The older we get, the atherosclerosis. Heredity really fits into just a few of the syndromes. So somebody says, in fact, a number of years ago, somebody said to me, you know, your grandmother had memory problems too, and your dad's lost a little memory, so you're probably at high risk. It's like, well, no, not necessarily. In fact, most dementias are not hereditary. But if the whole family had diabetes and strokes, and you have diabetes and you had a stroke, you know, you might be at risk. Alcohol use, smoking. The lack of education I put on the list, but this is one of these debatable things. If I had a working IQ of 140 and I had, you know, 7 graduate degrees and I lose 20 points, I'm still smarter than most people, right? But if I was kind of barely making it by and I could read most of the street signs and then I lose 20 points, I may be in big trouble, right? So in a way, education per se may not be helpful, but lack of education may be a risk factor. Down syndrome, head injury. We're becoming more and more aware of this. Chronic cerebral injury, repeated head traumas. And that's just kind of, you know, there was a big movie a few years back about football players. But there definitely is some truth in that, and we're becoming more aware of that. Okay, move on to neuropathology. By the way, if there's a pressing question, right, when I'm in the middle of something, don't hesitate to raise your hand. But we're going to kind of talk about the basics of the neurology of dementia for 45 minutes or so, and then 50 minutes. We're going to take a little break, and then we're going to talk about some of the social implications and spiritual implications for the second hour. And especially for that hour, I would welcome insight from audience members if they can illuminate the rest of us about some of the problems that they've dealt with. Okay, so people say he has Alzheimer's. What's going wrong with his brain? And when I was an early med student, I used to think I understood dementia. And then over time, we've come to realize there's a lot about even Alzheimer's that we don't understand. We do understand that there's an accumulation of plaques and beta protein and fibrillary tangles, intracellular protein tau. We know that neurons actually die and that the brain gets smaller over time. But on the other hand, there are many octogenarians whose brains have shrunk 20%, who still can do the New York Times crossword Sunday puzzle in ink, right? So the shrinkage of the brain per se is a factor, but on the other hand, many people's brains shrink and they do pretty well anyway. There's this concept of neuroinflammation. And again, some people say, well, you just have to take anti-inflammatories or vitamin E or vitamin D, but some of those haven't really borne out either. So there's a lot that we don't understand. There are some blood tests that show some promise, and we'll talk a little bit about them, but at present, none of them have FDA approval as being authoritative. I'm going to talk just a little bit about the medications for Alzheimer's dementia. But if you notice on this slide, I am not endorsing these per se. They're listed for reference only. And if you read about any of them, what they will say right up front is, there is no cure for Alzheimer's, okay? But some of these make a difference in the rate of decline. And the two at the bottom have actually been associated with a decrease in amyloid plaques that can be documented with MRI or SPECT or PET. But they're not without problems. And the average cost for Leqembi or Kasunia, lecanemab or donanemab, is like $20,000 a year. And you say, and what does that buy me? Does that make me as smart as I was 5 years ago? And the answer is no, but it slows things down a little bit. But if you think about that logically, you don't know where you would have been. All you know is where you are, and it supposedly slowed things down some, but you still lost ground, okay? Now, I think it was Dr. Mitchell who made the comment about my granddaughter's going to graduate from college, you know, my grandson's going to get married. I want to have enough wherewithal to be present for that celebration, to be a part of the fun. And if this will buy me 6 more months, I'm willing, as long as the insurance company will pay for it, I'm willing to go with the medicine. But both of these have been associated with CNS bleeding. A number of the specific dementias, not just Alzheimer's, but a number of the other dementias do mention that memantine may be helpful, and most of them suggest the use of one of the cholinesterase inhibitors. Now, if you think about how these three things are working, the cholinesterase, the brain operates largely on acetylcholine. So if the acetylcholine is going away and you can raise the levels, then you would think it would help. And so that's the rationale for all the drugs up top. A glutamate is considered something that damages the thought process in the brain itself. So if you could block glutamate, maybe that would help. And then the two at the bottom, if you can decrease the amyloid plaques, would that be helpful? And the answers to all of these seems to be kinda, sorta, which is an interesting American colloquialism, kinda, sorta. Anyway, they do help a little bit. Now, when you're trying to make the diagnosis of dementia, we'll move on to the next slide. There are a number of confounding diagnoses. And one of my jobs as a neurologist, somebody comes into the office and you're trying to sort things out. What you want to really do is the vast majority of them are going to have Alzheimer's, okay? But what about that 20 to 40% that have something else or have a combination? That's who you want to find, because maybe you could do something completely different for them and maybe it would be helpful. So those who have a primary language issue, you think of frontotemporal dementia. FTD is actually kind of a wastebasket because there are three major groups of dementias that are called FTD. The behavioral variant is the most widely known. Personal reflection, my older brother died in March. He had a PhD. He was a secondary school teacher. He got fired from several jobs, one after the other, because he just wasn't acting like a real adult. He told me one situation, he said, that kid was so disrespectful. And I said, well, he's a high schooler, you know. You know? And he said, so I said to him, there are only two people in this argument, and one of them has a PhD. And I said, what kind of stupid comment is that? You know, that doesn't prove anything. But that's the kind of social cues he was beginning to miss. But nobody made a diagnosis. So he went to another job, and he had trouble handling the new complex computer program that was supposed to put grades on for the helicopter parents who wanted to know every night how their Johnny or Joni was doing. He couldn't get it, so he got fired from that job. He went to a third job teaching, and it was a private school with some kind of elite snobby kids, and a few of them got his number, and they just started punching his buttons. And instead of saying, they're being jerks, you know, so what? He had to respond. And I'm like, no, you don't have to respond. Let it go. But it was too late. He got fired from that job. And so then, after a good career, being a coach, being a teacher, doing lots of nice things, he kind of goes down in ignominy, right? He loses 3 jobs in a row because it was undiagnosed FTD. And unfortunately, there's no great treatment for that. So he was treated with some things that may have helped a little bit, but not that much. Early movement disorders may signal something else, may signal Lewy body dementia or Parkinsonian dementia. And specifically, visual hallucinations are often associated with this. Parkinson's often has hallucinations, but they're relatively benign. One is, I see bugs crawling on the wall, and I know there are no bugs there, but boy, they sure seem real to me. And I say, well, if they're not biting you, and if they're not getting in the food, do you really care? And don't treat the hallucinations, because your treatment may be worse than the hallucinations, right? Gait disturbances, normal pressure hydrocephalus. A good friend of mine, who is a brilliant man and an author, physician, and an ethicist, came down with NPH, and he's kind of sidelined now. But the triad, for those of you who are familiar with this, but just as a reminder, urinary incontinence, cognitive decline, and what they call magnetic gait. Instead of the legs moving up and down as they walk, the magnetic gait is often like that. That would be a clue to normal pressure hydrocephalus. And the reason you want to make that diagnosis, if you can, is it can be treated surgically. If you put in a shunt before the situation gets too bad, it can be helped. Okay. Judgment, I mentioned that. Other things that can be confused as dementia and have to be separated are depression. Okay. Hallucinations, panic, other psychiatric disorders. Sometimes severe anxiety can almost come on and look like a dementia. So you have to separate those two out. And finally, delirium. Delirium, by definition, is the short-term response, metabolic response to something. Often it's a medication, an infection. So I would get called for a hospital consult, and Martha used to be outgoing and she was wonderful, and now she's all confused. Well, can I even make a diagnosis of dementia in that acute situation? Well, not really. I just say, clean up everything you can, get her CBC under control, stop the infection, clean up the UTI, and I'll see her in the office in 3 weeks and we'll see where we're at. And so delirium can be confusing there. Okay, next slide. This first one is important, specific to etiology. How many of you get emails or web feeds? If you just eat this Asian herb, you'll fend off dementia, right? Or if you just quit eating bananas, you'll fend off. There's a million of them, right? And I don't know how they got my number. It's AI, I guess, but I get those all the time. And I've gotten one lately from Dr. Ben Carson, who I love, but it's Ben Carson says memory loss is a thing of the past. I haven't contacted his office specifically to ask, but I assume it's a scam. I don't know. But you'll hear all kinds of, but the point is you need to find the etiology. And the reason you do is the treatment is completely different. And unfortunately, the treatment isn't very good for most of them. But you're primarily treating the symptoms. And I think this is really important. If somebody isn't sleeping, you don't assume it's the dementia. Maybe it's sleep apnea. Maybe it's restless leg syndrome. Maybe it's the fact that they're drinking too much alcohol. Okay, so you have to tease it apart. Now, I just put this on here as a reminder to talk about supportive networks are underused. And I said to Dr. Ritchie last night, I mean, he should be giving this talk. He and his wife, Rebecca, know this stuff. They've been dealing with it on a very personal level for a long time. But these supportive networks and respite, it's like, it's so important. And that could be a whole weekend symposium, just different ways that we as a church can intervene and be helpful here. I did want to mention the difference between palliative care and hospice. Again, this may be a review for most of you, but by definition, palliative care just means somebody has a complex medical history with severe disease that could take their life one of these days. Okay, that's palliative care. And so you can pick up somebody 5 years before they die and have a palliative care multidisciplinary team who are very, very helpful in making their life better. A great geriatrics clinic, or even an internal medicine or family practice clinic who care about those issues can make a big difference. Whereas hospice, on the other hand, is defined differently, but the key to the definition is, would it surprise you if this person were to die from their incurable disease within the next 6 months? That's kind of one of those key phrases. And if the answer is no, it wouldn't surprise me, you can talk about getting them into hospice. Now, hospice isn't a cure-all, but it is a multidisciplinary team for most people, for most situations, so that's important. There are some drawbacks to hospice, and some hospices are run almost like on a cookie cutter basis where somebody comes in, they have a little trouble breathing, this is what we give them. If they have a little trouble with pain, this is what we give them. And sometimes it's easy to stack a bunch of meds on top of each other, chasing the symptoms, when really you could do much better by having a supportive care network and not a new medicine. And that takes us to our next slide. Treat the patient, right, not the symptoms. Now, I'm going to come back to this eventually. You're not just treating the patient, right? You're treating the patient and the loved one and other people. But, you know, there's this TV commercial. It's actually for a new med for Peyronie's disease. But the guy says to his friend, I got a man for that. I got a man for that. I got a man for that. And some doctors are like, I've got a med for that. It's like, if you got a problem, I've got a medicine that'll solve it. And that's not a good idea, right? Polypharmacy can lead to all kinds of complications. And one way that I think of this is, if 1 plus 1 equals 2, if 2 plus 2 equals 4, but 2 squared times 2 squared, I mean, when you stack meds on top of each other, you're going to get a lot more complications than if you have 1 or 2 single drugs. So one of the principles that I used to work with med students is I would say, if at all possible, don't add 2 drugs at any time to a given patient. Why? Because then when they get a rash or they throw up or they can't sleep, you don't know what caused what, right? And in the patient who has dementia, you can cause a pseudo-dementia. You can actually hasten death. And Rebecca was talking to me specifically about this, that she has seen this in patient after patient, that when multiple drugs get added in to chase the symptoms, you can make things a lot worse. So side effects may be negatively synergistic. I like that terminology. Often the best treatment is not pharmaceutical, right? In the old days, how many of you saw One Flew Over the Cuckoo's Nest? I mean, it's an old movie, right? But it was a psychiatric ward, and they did all kinds of things that were crazy. But one thing they did that actually made sense is they had hot tubs they would put them in, and the heat can be very therapeutic. And there are other physical interventions that can be very helpful that don't require long-term consequences. So I probably got wound up too fast on some of these things, but I did want to kind of cover the bases. And I'm happy to answer any questions on this part before we go on to part 2 after a break. So before the break, is there anything that I've covered so far that you would like clarification on, or you have an observation of your own on? Yes? Can you talk a little bit about, so you're a neurologist, what do you feel your role is in care dementia? Well, first off, it's to decide if they have a dementia, or maybe they're depressed, or maybe they're on drugs, or maybe there's a whole list. There's a really long list of all the drugs that can impair cognition. And if any of you have taken Benadryl a couple days in a row for something or other, you can probably testify that you weren't firing on all cylinders. You weren't as bright as you thought you should be, right? Benadryl is a benign drug, but it can screw up your thinking. And there's a lot of drugs like that. So one of my jobs is to make sure that they actually have some type of dementia. The second thing would be to make sure it's not one of those other simple things that we could do something about, or a complicated thing. Like with my brother, for instance, if someone had made the diagnosis of frontotemporal dementia after he got fired from his first job, you get disability almost instantly with a diagnosis of FTD. And he wouldn't have ended his career kind of in shame. It would have been, he was a very good teacher, and then he got this bad thing, and we proved it. And yeah, he got disability, and he's got the support he needed. So that's another thing, is to prove what they have and to see if there's any intervention. And then it's to advocate for the patient. So for instance, if I had been as a neurologist and we diagnosed FTD, I would have said immediately, you need to file for Social Security, maybe on the way home today, because that would have changed his life, right? That would have made a big difference. And then the last one sounds like Marcus Welby, MD, and again, I'm showing my age. How many of you even know who he is? Okay, so some of you do. He was actually one of the reasons I went into medicine, because I thought he was so wonderful. And actually, I was watching old reruns of him when I made that decision. But is to advocate for him, not name it and turf him out the door. No, it's like, okay, now I'm going to be working with your family physician or your general internist, but I'd like to see you back in 6 months. And then we'd have to decide if he was a candidate for any of the meds. But we'd have a long discussion. What do these meds really do? What are the side effects? Can they be helpful? And then we'd have to be thinking, okay, what other things do we need to be thinking about? Which was the point of the second half of this talk tonight. This is not a criticism of all neurologists, but unfortunately, one reason I almost didn't go into neurology is it seemed like a lot of neurologists were trivia experts and very esoteric, and they wanted to know where the smallest nerve ran on the smallest muscle somewhere. And I just thought that was so stupid. I finally met a very nice neurologist who had a lot of common sense, and because of her, I ended up in neurology. But you can't abandon that patient just because you made the diagnosis. Now, if they had an extremely supportive family physician who was happy to take over all care and just have me see the patient once a year, that's fine. But a lot of family docs or general interests that I work with would say, I want you to be intimately involved in this ongoing care. So it'd be making the diagnosis, making sure it's right, talking over conceivable diagnoses, conceivable therapies, and then advocating and not abandoning. Other questions? Yes?
I got a question. Have you any opinion? I've just recently read about a research result up at Harvard about the use of lithium for possible Alzheimer's disease and the role of lithium in the brain. And I just wondered if you read that or have any thoughts on that as far as the potential drug use for Alzheimer's.
Yeah. He said he's heard a major study at Harvard where they were using lithium for Alzheimer's disease, and what I thought of it.
This has only been tested, the research is all in mice, but they were able to create the same types of changes in the neurons and the axons and stuff in the mice genetically induced, and they gave them lithium, and they were able to reverse a lot of these changes in mice. Now, they haven't had human studies yet, but I was just wondering, because of our use of lithium in bipolar disorder and other things, if you had any thoughts about, does this hold much prospect?
Yeah. So his comments are, lithium, they created a mouse model for dementia, and lithium actually showed some changes in the brain patterns of the neurons. I don't think that's stupid, but I think it's early. And I think it's important as Christians and as physicians to say firmly what we believe firmly, and to not say what we don't know, and to say what we don't know in a way that reveals that we don't know. Um, People bring up all kinds of things, and the interesting thing is some of them are going to eventually work, but along the way, you have to really prove it works, and you have to prove what the risk-benefit ratio is, and what kind of problems does the lithium create in other people, and does it have any specific complications in patients who have dementia as opposed to mice. So when I read something like that, I think, who knows? By the time I get demented, maybe they'll put me on lithium. Could be. Uh, and a lot of epilepsy drugs, for instance, have been used not only for epilepsy, but for migraines, for mood disorders. Depakote's a prime example. Valproic acid is used for a number of things. And lithium may end up being something one of these days, but not ready for prime time right now. So I'm not investing stock in lithium mines, but I could be surprised. Yeah. Pardon me?
Sundowner syndrome. So what about, I've started giving him a little bit of melatonin. What do you think about that?
The question is, someone she loves has sundowner syndrome, and she started giving them some melatonin. Sundowner syndrome is not a diagnosis per se, but it's kind of a symptom of a lot of different dementing illnesses. So I think it would be important to know what the real diagnosis was and what other medicines he's been on. The other thing about melatonin is your brain produces melatonin. So you say, well, that's not a bad thing. But like a lot of things, it's the amount of melatonin. And in older patients, it's start low, go slow. And so I wouldn't, if I had a loved one who had that, I would work with the family physician and I would say, here's what I'm thinking. Does this seem reasonable? The other thing it brings up is if you have a loved one and you've been working with the family doc or the general internist or whoever, the geriatrician, do you want at some point in time to consider being evaluated at a quaternary dementia clinic of some sort? Would you consider enrollment in a clinical trial? And those are all legitimate questions.
The problem with that, he has a PhD himself, and we tried that once, and the doctor introduced himself, said he was, what he was, and he realized that's what they were going to do. And so he shut down. He will not talk to any doctor that he knows is going to evaluate him for that. That's my problem.
Well, we talk about the Imago Dei, and we talk about the fact that even when loved ones make decisions that don't make perfect sense, we need to respect their decisions as much as possible, unless they're going to be directly injuring themselves or others. So sometimes I would just say to a patient, I don't think that your suggestion is crazy, but I'm not sure I'd recommend it. And I don't think I'm going to prescribe the medication you've asked for, but I'm happy to refer you to, Mayo or Washington University or wherever, if you'll go. And the other thing is, we all change over time, and sometimes people who have very firm, stubborn opinions about something will change, especially as they see the ramifications of their current decisions not panning out perfectly well. Yeah, it's tough. It's tough because it's a free country and they are allowed to do a lot of things as long as they're not hurting you or the children or whoever. Yes.
So I'm a lay person, not a medical person. The risk factors, my mother had none of those. Okay. Educator for 41 years. She's now in good stage 5 of dementia.
How old is she?
She is 82 years old, still beautiful. Okay, you wouldn't know unless you talked to her. And they live in bluegrass assisted living. They're loving it. She doesn't miss bingo, so all's good. But as her child, and I've seen how she's lived, I worry about, you know, factors that might have increased her chances. And I'm just going to ask you this, okay? But my mother had a lot of arthritis, and so she had both hips replaced, both knees replaced. She had breast cancer and had a major surgery. And it seemed like every time she came out of anesthesia, my mother was a different person. Is there any research being done about the impact of anesthesia on, I don't know, so on dementia, I mean, can that increase their chances? Because it seems like that's what started it for my mother. I mean, it's a really, every time she was different.
I think that's a legitimate observation, and if it's a routine elective surgery and you don't need to get it, I'd say don't get it. But if she couldn't walk because both knees were so crippled up and she was in pain all the time, you know, it's a risk-benefit analysis, and you end up saying, well, maybe I'll do that.
She's walking 5 miles a day. It's just, you know, she wore them out. But she had arthritis. But
Yeah.
her last knee was where we really saw, it's like, oh my goodness, the look, you know, that look, where you're not there. I saw that after that, and it's really scary. And so I'll avoid those surgeries. So.
If you can, yes.
So I just speak to that as a surgeon. You have choices called spinals, called epidurals, called all sorts of things. And there is some data that shows that anesthesia, general anesthesia, knocks you down. You know, people talk about, the bounce back. That's not always true. Okay? So it's a little anecdotal, but there is some data on that. I don't know how specific the statistics are, but I just encourage you to know that you have choices with anesthesia to talk about, especially with like knees and stuff like that, but you don't have to have general for a lot of.
Good point. One of my neurology professors had significant valvular heart disease, and he refused to go on the pump because he was convinced that if he had general anesthesia and was on the pump, he would lose a lot of ground. And he was kind of an obstreperous guy, but he was brilliant. And for him to lose any of his brilliance would have been devastating. So he lived with his bad heart valve for a long time. Okay, well, time to get whatever you want for a few minutes, and we'll get started up. The last hour, we'll be discussing a lot of different issues about how dementia in its various forms impacts the families and the lives. And I will be hoping for more audience participation. I like giving these talks because I learn stuff from the audience a lot of times. So thank you.